So with that, I will turn it over to Jamie. Jamie, welcome to WDI Feminist Question Time. It's a pleasure to have you.
So on July 9th, here in the United States, the Federal Trade Commission held a workshop which they titled The Dangers of Gender Affirming Care for Minors. And this workshop was focused on potentially unfair or deceptive trade practices in the provisions of what they referred to as gender affirming care for minors. This was one of the first times that the federal government has been weighing in on this topic in the United States. The Federal Trade Commissioners spoke first, and then they hosted various panels, including some doctors, medical ethicists, whistleblowers like myself, detransitioners, and parents of detransitioners. One of the most powerful and impactful panels actually opened first with a father and son who were both just overcome with the emotional grief of remembering the time when the son was identifying as trans. This workshop raised concerns about whether consumers were being exposed to false or unsupported claims regarding the benefits and risks of such interventions. And the workshop coincided with the Department of Justice here announcing investigations and subpoenas being sent to 20 clinics, investigations looking into providers of this care alleging potential healthcare fraud and false statements. Before I share my testimony from that day, I will highlight that one of the most impactful of the day was Glenna Goldist, who took apart the fraud at the very core being about language and the concept of gender itself. Very impactful. So this was my testimony from that day. My name is Jamie Reed, and I hold a Master's of Science in Clinical Research Management from Washington University in St. Louis, Missouri. I'm a lifelong Democrat, a mom of 5 boys, and a lesbian. I am also the public whistleblower from a pediatric gender center. I participated in transitioning nearly 1,500 unique patients who ranged in age from 3 to 26 over almost 5 years. I was once a true believer in pediatric gender medicine, and now I understand I was participating in an industry that was based on fraud, deception, and in layman's terms, it was running a racket. Patients with significant comorbidities were treated using unethical and deceptive informed consent practices. They were not properly assessed, informed of their conditions, or given a diagnosis. A diagnosis is the first step for any consent to be valid and not fraudulent. These were also vulnerable patients who required specific safeguards. First, they were minors and should be provided additional safeguarding protections. Second, they had significant presenting comorbidities, often falling within the definition of a stigmatizing complex medical disease and sometimes even meeting the criteria for a legal medical disability. These comorbidities include, but were not limited to, autism spectrum disorders, anxiety, depression, borderline personality disorders, eating disorders, self-harming behaviors, somatization disorders, learning disabilities, ADHD, and significant trauma histories. Third, many of the presenting patients, before we look at the social contagion cohort, will eventually, if not medically treated, be homosexuals, like me, is that they will identify as gay, lesbian, or bi. The entire diagnosis is based on regressive stereotypes and self-described feelings from minor children and their parents. My clinical experience also show that these, quote, biopsychosocial assessments are not consistent, comprehensive, or truly diagnostic. For an assessment to be diagnostic, there is a very simple way to prove if it actually is so. It's so simple that many of us forget. There must be a statistically significant number of patients who do not meet the diagnosis. In lay terms, the statistically significant number of patients should be told no. And in gender medicine, this does not happen. I might hold a Master's of Science in Clinical Research, but that is not a requirement to understand this basic concept of medical diagnostics. Parents and the public have been deceived into believing these assessments were consistent, comprehensive, and diagnostic, and that no child ever was receiving these treatments without them. If the assessment met the criteria of consistent, comprehensive, and diagnostic, providers should have been able to produce the assessment tool for analysis, The assessment tools should be universally consistent across our states, and they should have been able to show data of what percentage of those presenting were being told no. But this, and this is a huge but, even if the field was actually doing what it claimed, even if it was completing a true biopsychosocial assessment and saying no to a statistically significant patient population, please know that those in the end who would still have been told yes, would be homosexuals like me, and especially the quote, gender nonconforming homosexuals. Under the Dutch model, they would be deemed okay to be rendered sterile without sexual function and with destroyed endocrine systems, and to die early, simply because they are gender nonconforming homosexuals. So, to the Laura Edwards Leeper and Annalou DeVries of the world, we, the gay, lesbian, and bisexuals, are no longer feeling like it's okay to be harmed for straight people's comfort, and we are fighting back. I personally witnessed the consequence of prescribing these treatments without proper informed consent. One patient, after a mastectomy at 19, begged for her breast to be put back on. This harm has not been contained to children or minors. Another patient's intellectual functioning was so impaired they could not identify to me where they lived or explain what kind of identification they possessed. Multiple staff members expressed concern about their ability to consent to any medical procedures. And despite these red flags, the patient stated that they also desired to have biological children, yet they were prescribed a treatment that would ultimately sterilize them for life. We, as the clinicians in the gender industry, would openly state, quote, it does not matter if patients meet diagnostic criteria or if patients even actually have gender dysphoria as defined by the DSM-5. If a patient said they were trans, they were trans. Parents were unaware that patients were self-diagnosing, that clinicians had completely abandoned the diagnostic process entirely. And patients and parents who didn't agree with our lies were isolated, abandoned by our center. We tore married parents apart, and we tore children from caring parents who told us no. Imagine in a different field if children were self-declaring that they had malignant cancers to an oncologist. Then, without labs or biopsies, these same children demanded chemotherapy or surgeries, and the clinicians were just complying. Then clinicians would bill insurance for these procedures and medical visits, making money from the hospital, for the hospitals, and for themselves based on this deception. This is precisely what we are doing in gender medicine. We expanded this deception into a racket. We created a list of gender-affirming only therapists who would do exactly what we wanted. A therapist could only get on this list if they would comply. We needed a letter, so we also gave them a fill-in-the-blank, pre-drafted, ready-to-go letter. I know this because I not only helped create this letter, but I emailed that out to the same therapists for hundreds of our patients. I wish I could say that I became a whistleblower the first time I heard the nurse say, but Dr. Luce, we are committing insurance fraud, because that was said, and I didn't. I wish I spoke up sooner. The final death blow to my ethical medical soul that finally led me to speak up is that we were directly harming patients. We didn't just deceive them or their parents. We hurt children. And to that same Dr. Chris Lewis, I said, Chris, we are harming patients. And he said, I know, but what do you want me to do about it? I hurt the very children I was employed to protect. St. Louis Children's Hospital mission was simple. St. Louis Children's Hospital will do what is right for children. We did not. And now all of us must reckon with what we have collectively done. I now am running a nonprofit with Lauren Legere. She was on a previous one of these panels, and we call it the LGB Courage Coalition. I know that Bev is on this call from the UK, and in some ways I like to think we are one of your sister organizations in the US. The LGBT Courage Coalition is a lesbian and gay advocacy group that we are committed to promoting evidence-based medical care, ending the medicalization of gender nonconformity, safeguarding homosexual rights, and building a pathway back for LGBT individuals who have undergone medicalization. We believe that no child should be subjected to the material harms caused by puberty blockers, cross-sex hormones, and gender-affirming surgeries.
In a podcast with Trigonometry, Jamie has said that the topic most in need of discussion that wasn't being discussed was homophobia. Thus, the question, quote, how does homophobia, particularly of butch lesbians, push women and girls into a trans identity?
Trigonometry was one of the first podcasts or interviews that I completed. And I did not even know that they did that at the end where they asked that question. So that was purely from my gut when I answered homophobia. What I did not understand when I worked in the gender center, and what I do understand now, is that the entire basis or concepts around trans rely on a couple of underlying feelings. And one of those is based on our historical inability to address homophobia. So when we look at the historical understanding of how trans came into existence, in a lot of ways, almost all of the early transitioners who, especially the women. So when we look at the women who were seeking transition, it was almost entirely lesbian women who often were in a relationship and seeking a way to have that relationship made valid or legal or even just able to exist in the time period that they were in. I understand now that the current cohort that is identifying as trans is often not homosexuals, but the concept of trans itself has always targeted homosexuals. I also know right now that lesbians are in the same cultural soup that everyone else is in. And right now, for these young people, that's all about labels. And so they are not really presented with this idea that they can be a full human being and they don't have to come up with this whole catchphrase. It's all about what label they're picking up on. And right now, even the label itself of butch or femme is completely not being used by young people. Really, the concepts that they have presented to them are either you're trans, you are non-binary, or your sexuality is something in a very weird list of pansexual, all of these different concepts. But even just being a lesbian is not really being presented to kids. So in a lot of ways, I feel like we're not going to be able to step kids back from labels, but what we might be able to do is at least step them back from physically damaging and harming their bodies. And if I had to choose, I'd much rather a whole bunch of kids identify as butch right now than trans, because butch at least doesn't mean that they're going to be undergoing testosterone surgeries or any other thing that's going to harm their body in the long term.
When and how did you realize that there are no trans kids? So I'd love to hear your answer to that. But also, in response to Heli's observation about the Dutch protocol, in your testimony before the FTC, which you read here, you mentioned a woman whose name I'm forgetting, but she's the one who took the Dutch protocol and brought it to the United States. And people probably don't know about that. So can you answer the question, when and how did you realize there are no trans kids? And also, could you explain a little bit more about the woman who brought the Dutch protocol into the United States and what happened?
I don't just say there's no trans kids. I don't know that anyone is trans. Um, I believe that there are individuals who might experience distress around their sexed bodies for extended periods of time. I don't know that we've ever been able to verify that that's something that would continue through the lifespan. But the concept that no one can change their sex, regardless if you're a child or an adult. So really the entire concept around it doesn't, there's no logic behind it. When I first realized there were no trans kids, early in my tenure, there was a debate between the endocrinologist and the adolescent medicine doctor. The the adolescent medicine doctor believed we were treating this mental health condition called gender dysphoria. The endocrinologist didn't care if patients met that criteria. He essentially said, if they claim that they're trans and what the drugs that we can give them line up with what they want, then he was willing to give them this. And it turned into this very interesting debate between the two over whether or not this was purely cosmetic. That was right about when I realized, oh, this is not based on anything. If the two co-directors can't even agree on what they're even treating, we're not, this is basically made up. In terms of who brought the Dutch protocol to the US, the Dutch protocol is the use of the puberty blocker. Giving minors cross-sex or wrong-sex hormones had already been disseminating out earlier than the Dutch turned this into a specific protocol. It is the puberty blocker itself that is what makes it stand out. And the clinic was in Boston. It was called GEMS. The endocrinologist was Dr. Norman Spack. He sent early in her training psychologist named Dr. Laura Edwards Leeper to the Netherlands to learn the protocol and bring it back. One of the interesting things that came out of the New York Times podcast called The Protocol was that she only went for a week. I thought she actually spent closer to an entire semester. There's questions on whether or not she knew the language. So if someone was translating for her, she doesn't speak, she speaks only English. So how much can you actually glean in a week's time? But Edwards brought it back. Edwards then really disseminated this out through the US. And then the reason why her name pops up is because there was an early op-ed that was published where she was basically criticizing the US model, saying it went too far, too fast. There was not enough psychological assessments, which is what she believed her role was. But Norman Spack was the endocrinologist. One of the early questions I asked Laura when her and I started to communicate was I asked her how on God's green earth did this come to the US, and it was not a clinical research protocol. She could not answer. She didn't know how Norman Spack started doing this there, and it wasn't under clinical research guidelines.
Will we stop literal pediatric transition, but still allow young people as young as 18 and 19? Will society sort of accept that as a compromise? And what do you think about that?
It's an excellent question, and it's one that a lot of us have to, I think, pose for ourselves. So the issue, though, is that trans as a harmful ideology does not stop at any age group. And parts of the problems that we see for women and children especially is when adults transition. So our kind of stance right now as an organization is that children are our primary focus. We do believe that there is legal precedent for there to be laws so that there are bans against these harmful interventions in children. What we hope to see for the adult cohort is a couple different mechanisms we think we can pull on to at least completely scale this back. So one would be the removal of any insurance coverage. So we do hope that no age should have this be paid for out of an insurance plan, be that a public insurance plan or your private employer plan. We don't think this should be covered or considered medical treatment. So we do think that if we can scale back a lot of the dollars in this, that we can get this rolled back out of the adult cohort. The next questions for the adult cohort become, do adults have the right to harm themselves? And so legally, and Kara, you're more of a legal expert in these things than I am, but legally, do the adults have the right to harm themselves? We think most ethicists would argue that yes, adults have the right to, you know, implant things or cover their face in tattoos or do these things that we know would be harmful. The question then becomes, do doctors have the right to harm their patients? And so, what we're hoping is to pull out all of the funding and then pull back also that doctors have to look at this for what it is, which is medical harm, and that doctors should not and do not have the right to harm patients. And so where we do not think, I personally do not think we're going to see bans or laws against this for adults just because of the legal mechanisms. We're hoping we can pull on all of these other strands to at least chase this concept back into the smallest, darkest corner that we can possibly put it in. And then basically all of us need to stay on guard and make sure that it never rolls out again.